Ladies and gentlemen, would you start making your way back to your seats, please? Thank you. We are going to restart the afternoon session in 2 minutes with addresses from the sections. Welcome back from your break. Folks, we'll restart the afternoon session, and this is exciting, we are a little bit ahead, so we might finish early, or we might have enough time to finish resolutions today and be finished early tomorrow. We'll see. We know that sections have been meeting over the past few weeks, and we look forward to hearing from them, as well as from other members and delegates on important topics affecting the profession. We'll now open the floor to delegates who have business that they want to bring to the Assembly. And we'll use microphone 1 over here on the left side of the room as you're facing the stage, and we'll use microphone 2 in the center of the room. So if you have any business that you'd like to bring to the Assembly, please come on up to the microphone, and let's start with microphone number 1.
Hello, Dr. Carissa Brabant. I'm a delegate from South Central. I work in family medicine, but I'm here today to advocate for anesthesia. At this stage, we are currently at a drastic lack of anesthesia support in our area, despite the fact that we need that support for our surgeons, for obstetrics, to be able to provide care for our patients. And I've been hearing that a lot of the delay and lack of getting anesthetists in our area is because of contract negotiations not going very well, and about the ministry / SHA wanting more from the anesthetists that they are able to safely provide, including a lack of post-call days and requirements for being on call excessive amounts of time with not enough time off. And so I wanted to ask what the SMA is doing to step up and stand up for their anesthetists as they go through these contract negotiations. And is it at all possible to get the SMA contract negotiation team involved at the beginning instead of at the end when the physicians are complaining about the contract, make it so that the SMA is there during the contract development period?
Thank you. And I should have checked with Ivan and team. You have someone recording all these concerns, I know. Do you have anyone that wants to respond to any of those, or just that you've recorded them? It won't be me. We welcome Ed.
Hi, Ed Homday, SMA staff. I am familiar in terms of this particular situation, and the negotiations are ongoing, probably not as expeditiously as what we would hope. I think the point is well taken, though, in terms of the timing of the SMA engagement, and I think it would be better for all the parties if we were privy to those conversations at the time these things are putting together, rather than having to react to them, which in the variety of cases is what happens. And so I think it's a conversation that can be had with the health authority in terms of what we might do a little bit different and better. And again, in terms of the specific contracts and the issues in terms of anesthesia specifically, what was identified are items that are on the table, and we're working through them. But I think in a larger sort of picture, the earlier engagement of the SMA would expedite the conversation on a number of fronts. So point well taken, and we'll engage the SHA in a meaningful conversation about how things can be rearranged and sequenced in terms of getting these contracts in place quicker.
Thanks, Ed. Can we come to microphone number 2, please? And I'm sorry, before we do that, Dan and company, can I have a timer up for this, the 2-minute timer? Please go ahead. Sorry to interrupt you.
Tamza Levendal, delegate from Northeast, MSA and MSA president there. We just recently heard about the SHA becoming more operational for the health authority than helpful in terms of us being able to access problems through them. Do we know anything more about that and how we could get some of our problems that we have through SMA sorted through the SHA if their role is more operational versus functional for us?
Who shall we ask to address that? Any takers from SMA staff or executive? Marcel, thank you.
So thank you, Marcel Nobert, SMA staff. I guess the hesitation to come to the microphone is we're not entirely sure we understand the question. So maybe we can get a little clarification on the operational and the...
Apparently, the SHA has been given instruction through the ministry that they will no longer be a functional part of health-making decisions, that the decisions would be mainly made by the ministry. And so their role, as we know it right now, might be changing.
Okay, I guess I wasn't aware of that policy direction. And if that is the case, then it would be important for the SMA to be involved in that conversation. So I think between our senior leadership team and our board, we'll ask some questions to follow up on that. But at the moment, I don't have an answer for you.
Okay, thank you.
Thank you. Any other delegates like to bring any issues forward? Please, microphone number 1.
Yeah, I was just wondering, again, Donna Lettingham, Love Medicine. We put forward the resolution around e-health and IT support within the SHA. And Dr. Jeffrey was gracious enough to send a letter to the head of e-health. I'm just wondering if there was any official response to our concerns. Anything further? I don't know, any comments from anyone noticing an improvement?
Any comments about that response?
It is now. Hi, Ivan Mazechka. Donna, we did get a letter back. It'll take me about 10 minutes to dig it out, and I can send it to you, or I can report to the RA about that.
Yeah, I mean,
I believe I did. I have to double check, but I thought we did.
if you don't mind reporting to everyone, I think it was a broadly based concern. I'm
Yep.
happy to share that.
Okay, give me a couple of minutes.
Thank you.
Thank you.
Can I speak to that, Kishore?
Sure, please go ahead.
So I'm Sean Groves, representative from the Northeast in La Ronge, far Northeast. I had an experience with eHealth the other day, and this is just anecdotal, but it was the first time I ever felt like I actually called about something that I thought was important, got a response back, and then went up the chain to a manager, and my response was heard, validated, and the response I got was, "We will work on this." And it was about imaging on EHR viewers. So just so you all know, if you go onto EHR viewer and you look up medical imaging and you try to select all, it only gives you 3 years worth. So you're not looking at all the past imaging reports, you're only looking at the last 3 years, even though it seems like it's all. But they did say they're aware of the issue, they're gonna work on it, and they're gonna try to fix it. It was a legacy thing that would bog down the system too much. So again, really quick response. This was all within 48 hours and 3 or 4 different emails. So it was really good.
Thank you. Any other comments or issues that delegates would like to bring before the assembly? Yes, please go ahead on mic 1.
Hi, Sheila Pry, Regina delegate. So this is actually something that was brought forward from a rural physician on a recent locum that I was covering rurally. So the question is around like the SIPA program. Apparently, in one community, they have been approved for a 4th SIPA doctor now, bringing the total community number of physicians to 6 physicians, with one physician going from a contract position to fee-for-service. Now, this was brought up as a concern because a neighboring town about 30 minutes away is having huge problems with their access. They only have 3 physicians, and it's an extremely, extremely busy center. So my question is there, I guess I'm looking for some clarification on how like physician recruitment resource planning is done, especially when you consider the differences between like contract physicians at primary health centers versus other fee-for-service physicians who are generally in a private practice and outside the scope of the SHA.
Thank you. So we have a question about resource allocation in rural family practice. Is there someone from SMA staff or executive that I can ask to comment on about that?
Kishore, I can maybe take this one again too. I'm Sean Groves again, La Ronge. I sit as the chair on the Committee on Rural and Regional Practice, which is partly responsible for some of the work around physician recruitment and retention in the province. And what I can say about this issue is it's obviously very complex. We have a physician recruitment organization, SaskDocs, that does work on behalf of rural communities and rural practices. We have the Committee on Rural and Regional Practice that does kind of focus efforts on recruiting and retaining physicians, developing programs to support physicians who work in rural communities. That being said, it's a very piecemeal approach that could definitely improve a lot with less kind of siloing in terms of announcements and integration. Even RPIP, the increase in RPIP funding we weren't aware of that until it hit the news, even though we're working as a recruitment and retention arm of the SMA. So those are things where I think there's a lot more opportunity for a more solid integration and connection with different organizations. I hope I was allowed to answer that one.
Thanks, Sean. Before I invite any other speakers, so Ivan and Donna, are you wanting to bring something to the whole group, or you're okay with just sharing it? Okay. I only have so much filler material I can drop in here, Ivan. Any other speakers? Questions?
Thank you. So the letter that went out was to Davin Church about wait times. And the response we got back, again, I won't read the whole letter, but he said, please know that we've put in place ITSA with the SHA. We are currently concluding service-specific agreements, which incorporate turnaround time guidelines for operational services, including hardware needs. Timelines may vary depending on the request. For example, specialized or non-standard hardware may take a bit longer. We are always willing to negotiate timelines with partners, appreciating the important work they do supporting patients and improving health outcomes. He also says here that eHealth is facing high demands for support. We are tackling requests coming in through various channels and recently launched a concerted effort to clear the backlog in a number of service areas, including requests for IT equipment, software, user accounts, and clinical system access. Because these backlogs affect provider services and frontline delivery of care, we've assigned a team of employees from across the organization to focus on the issue over several weeks with the goal of eliminating backlog and IT service requests by January 31. And he ends the letter with, in your letter you noted specific challenges laboratory physicians are facing. We are aware of examples cited. eHealth teams are working with senior leaders at the SHA to prioritize and address numerous requests, including those related to laboratory services.
Thanks for finding that. Any other speakers? Anyone else like to bring up any issues from your association or your section? Okay, thank you for everyone who did. We are now at the first resolutions portion of our meeting. This year we're delighted to have received many resolutions in advance, and these were submitted to the Resolutions Committee for review. And so thank you for submitting them in advance. We do have a hard stop in this room at 4:30 today so that the hotel staff can prepare for dinner. We have many resolutions to get through, so please, if you would like to make comments, we invite you. Please make them concise. Can I see the first resolution, please? This would be resolution number 9. Thank you. Be it resolved that the SMA advocate for rural and regional physicians, including specialists, to be paid at a differential rate that is based on the location of their work, as is done in some other provinces. Moved by Dr. Francisco Garcia, seconded by Dr. Kayla Fair. Dr. Garcia, would you like to speak to the motion?
Yes, please.
Go ahead.
So, Dr. Garcia, I'm a urologist in Swift Current. What this really is an extension of already us mimicking a little bit from the BC model. This is something that's already been discussed, reviewed, implemented, and signed in BC. Basically, it's a intricate point system, basically giving an isolation score, and then therefore translating into a percentage increase for reimbursements for those who are more isolated in order to try and help with the retention component of those who are more rural communities. And it would be applied to whether they be in an AFP, whether they be a percentage in a fee-for-service billing, to basically to make an account for the more isolation and less services that you have to support you when you're in those communities.
Thank you. Would anyone else like to speak about this motion? Not seeing any other discussion, then please have your Slido browser ready for voting. Oh, I'm sorry. Oh, I'm sorry. Pardon me. Please go ahead.
Sorry, I stood up late. Steve Loden, family physician, Meadow Lake. I'd like to speak in favor of this motion. I think I have a little bit of experience with the BC system, and I think in theory what it would address quite effectively is it wouldn't be as much of a piecemeal approach such as we had recently, where we had the benefit for rural family physicians, which doesn't really address some of the issues of the regional sites, and I think this is something that could be explored with our upcoming funding models. So I would speak in favor of it. Thank you.
Thank you. Can we continue on microphone 1?
Renuka Prasad from Section of Psychiatry. This is a novel idea, but I just want to seek some clarification regarding how does it work, particularly if you are using a remote way of you visiting or assessing the patients. How does that pan out?
Dr. Garcia, do you want to address that?
Yeah, my understanding is that it's based on primary practice location is the way that it was used in BC. I could be wrong. There's a lot of PDF documents in the signed documents from BC. But when I was looking through it, it looked like a primary practice location was where it was, or sorry, where the service was delivered, I really should say. So you could have multiple practices, but it was where the service was delivered. So I guess in that case, if you're in an urban center but doing remote viewing virtually, it would be considered urban.
Would anyone else like to speak about this motion? If so, then let's go back to the Slido polling browser, and I would like to open the polling now, please. You have 30 seconds. Polling has ended. And we'll see the results. This motion is carried. Resolution 10. Be it resolved that the SMA make its best effort to ensure that there is appropriate representation of rural regional specialists at the table for any negotiation of contracts fee for service or call obligations. Moved by Dr. Francisco Garcia, seconded by Dr. Michael Capusta. Dr. Garcia?
Thank you. So I was double tapped by my president, so I'm here. So basically what this is getting at is not just theoretical. This is actually in response to a couple of times where there have been committees that have been formed to make decisions that affected call responsibilities, call reimbursement of those who are specialists in rural communities without any input from those same specialists, nor any representation on those committees. And what the hope of this resolution would be to ensure that, at least going forward, if there are any of those committees' decisions that are being made, that the opinions, views, and representation of those rural specialists should be included, if not represented at least, and having their voice heard at the table.
Thank you. Would anyone else like to speak about this motion? So we will put the motion to a vote. So please open your Slido browsers, and we will start the polling in a moment. Has the polling started? Okay, thank you. Polling has started. And polling has ended. Resolution 10, that motion is carried. Resolution 11, be it resolved that the SMA convene an intersectoral working group to address concerns about expectations physicians have about follow-up by their colleagues for patients seen in consultation without a direct discussion of roles and responsibilities for the care of the patient. Moved by Dr. Sean Groves, seconded by Dr. Etienne Krause. Dr. Groves?
So thank you, Sean Groves from Far Northeast delegate. The point of this resolution is really to get back to this idea that as physicians, we work together in providing patient care. You know, with the move to electronic forms of documentation, automation of how we communicate in the system, we've lost a connection particularly between family physicians and consultant physicians in terms of the relationships we have with each other. And that's led to differences in terms of what we expect of each other. And at many tables I've sat at, I've heard family physicians complaining about some things, you know, in terms of follow-up or arranging tests or, you know, coordinating care that they thought their consultant colleagues were responsible for. And on the flip side, I've heard consultant colleagues saying the same thing, you know, we want to pass care back to family physicians and it doesn't seem to be happening, or it doesn't exist. And I think it's something as a group of physicians we need to start looking at and finding a way to address it. And so this ask is really to get some family docs and consultant physicians together to at least put our finger on the problem and understand what it is, because I don't think any of us really fully understand it. And then also to work on creating some expectations. And I'd rather see that happen through the Saskatchewan Medical Association than through the CPSS with patient complaints, or through the CMPA with, you know, negative outcomes because of poor communication. So that's the impetus behind this. So hoping you'll consider that.
Thank you. Would anyone else like to speak about this issue or this motion? So we'll open the poll and we'll call for a vote on Resolution 11. So please open the polling. Polling has started. You have 30 seconds. Polling has closed, and that motion is carried. Resolution 12. Be it resolved that the SMA advocate for an increase in funding to the retention funds. Moved by Dr. Barb Konstantinowicz, seconded by Dr. Etienne Krause. Dr. Konstantinowicz?
Thanks very much. Over the last several years, there's been no change in the amount of the retention funds, and we were thinking about how to best be fair to those of our colleagues who are more senior, especially as they're getting closer to retirement and have spent their life in Saskatchewan. So we thought increasing the funding to the retention fund may be worthwhile for the SMA to review in terms of a new equation, perhaps dealing with inflation.
Thank you. Please, Dr. Garcia.
Francisco Garcia, Urology. I'd like to speak in favor of this resolution, and I think it goes even, beyond Dr. Konstantinovich is saying that I think the best incentive to recruitment is retention as well. So if you'd rather go work in a place that has a very low turnover, very low vacancy rate. So if we can continue to support and reward and reimburse the physicians that we have, and showing that they're supported, it's going to be a lot easier to recruit as well. So there's two bonuses, I think, to this.
Thank you. Anyone else like to speak about this issue or to this motion? Okay, we'll vote on this motion. Please open your Slido browsers, and we'll start the polling. Polling has begun. Polling is closed. And sorry, it's driving me crazy. Usually I'm pretty good with names of songs. What is this song? Who sings it? Thank you. Hootie and the Blowfish. And back on task, this motion is carried. Oh. Sorry. Resolution 13. Be it resolved that the SMA advocate for an increase to the Continuing Medical Education Fund to reflect the real costs of an educational event, costs of travel and accommodations, along with the overhead costs when a physician is absent from their office. The funds paid to the physician must accurately reflect the costs associated with attending an educational event. Moved by Dr. Barb Konstantinovich and seconded by Dr. Etienne Krause. Dr. Konstantinovich?
Thank you. I Googled one day, how quickly does medical knowledge or information double? 1950 doubled every 50 years. 1980 doubled every 20. 2000 doubled every 2. 2020 doubles every 70 days. For us to keep current, we spend a lot of time all day, every day, looking things up to date or calling our colleagues. We need to really sort of think about how we do that continuing CME on a regular basis. Most CME events are pretty pricey these days. The cost of them has gone up. Even the virtual, if you're attending virtually. And the cost of being away from your office, the cost of travel. So we would appreciate the RA's attention to this matter. I think it would be something that would be of advantage to every member. Thank you.
Thank you. Please.
Could I propose a friendly amendment, or maybe this needs to be a separate resolution, but in terms of restructuring how this is paid out, I think I had asked at one time whether or not we couldn't use our CME funds not to go out, but to bring people in, and that was rather ill-viewed. So is there a way we could restructure this program to more broadly modernize it or make it more useful, also to bring outside expertise to the province to help us?
Do you want to make an amendment to this motion?
What's going to be easiest for the resolutions committee?
My feeling is that it would be quite challenging to amend this motion to reflect that. My feeling is that that would be a separate resolution.
Number 2? Okay, sure.
So then we should submit that resolution prior to 10 o'clock tomorrow morning? Okay, great, thank you. Would anyone else like to speak about this motion? All right, we're going to open the polling for Resolution 13. Polling has begun. Polling has closed, and this motion is carried. Resolution 14. Be it resolved that the SMA consider a campaign of advocacy for childhood immunizations, as rates in some parts of Saskatchewan have fallen as low as 50%, well short of the target of over 90%. This motion is from Dr. Kayla Fair and seconded by Dr. Claire Kozrowski. Dr. Fair?
Hi, I'm Kayla Fair. I'm a member of the Southwest MSA delegation. This resolution was brought to our attention from our local MHO as some areas of the Southwest have seen a significant drop in childhood immunization rates to some areas as low as 50%. And there's a general decrease throughout the province in childhood immunization rates, especially since the pandemic. And so we believe that it would be beneficial for a concentrated public awareness campaign as a part of a strategy to help increase those numbers.
Thank you. Microphone 1, please.
Thank you. My name is Dr. John Marco Pondo. I am the chair for the public health section of SMA. So I'd like to support this resolution on behalf of Dr. Fair and the Southeast physicians, not to bore us all and remind us how immunizations are really an important foundational protection and really saves us in many ways, whether as physicians. It does reduce the volume of demand for our hospitalization and acute care. So certainly this is something we've seen, pandemic and other things. Childhood immunization is a foundational part of public health and part of healthcare, and I definitely support this. Thank you.
Thank you. Dr. Hayden?
Oh, okay. Hi. So I guess I wanted to ask a question about it. I just know that any sort of campaign is extremely expensive and time-consuming, and I guess I theoretically, philosophically agree with this. It's more a matter of what's meant by a campaign, and I assume that just doesn't mean writing a letter. And so when we talk about resolutions, what exactly is meant? What are you envisioning with respect to this?
I'm not sure that we had a specific template for this, but I think either a social media campaign or working like awareness or working with the SHA, if there's a more appropriate measure to try and disseminate some accurate medical information about this to the public.
Thanks. Microphone 2.
I am the seconder. That doesn't close debate or anything
No.
interesting like that. All right. Yeah, we try not to operationalize or dictate how this can be achieved by the SMA, and I fully expect that the SMA will cooperate with partners, quite a few of them, to forward this effort. The other I find interesting pieces that our public health doc asked us to pass on were that the WHO, the World Health Organization, has noted with great concern the reduced rates globally since COVID and has announced, in quotes, the big catch-up. We really need to be part of that big catch-up. The neighborhood that I live in is full of mis and disinformation, and the southwest corner of the province is now being threatened by pertussis, which is coming across the Alberta border and again causing clinical concerns. So we'd like to work on this sooner and then later perhaps on a grander scale. Thank you.
Thank you. Microphone 1.
Thank you, Mr. Speaker. Namdi Ndobuka, MSA delegate from North Central. I'd like to speak in favor of this motion. I work in public health, and most recently, there was a National Immunization Week that was just concluded late April, and the province took a very concrete step to work collaboratively with the SHA and First Nations jurisdiction to do a province-wide campaign. And we did see a lot of value in that particular campaign, but I think this particular motion speaks to the fact that we need to sustain that momentum above and beyond the National Immunization Week so that the province will be able to do that catch-up that the WHO have recommended, not just for the province-wide, but also for the underserved population that are still struggling with rates as low as 50%. Thank you.
Thank you. Any other comments about this resolution? Then let's have the polling on Resolution 14, please. Polling is opened. Polling has completed. This motion is carried. Resolution 15, be it resolved that the SMA advocate to the Ministry of Health to implement an electronic surgical referral system such as that was recently announced in Nova Scotia to allow for better waitlist management, the ability to triage consultations appropriately, and inform patients and referring physicians and nurse practitioners about available referral options. Moved by Dr. Sarah Miller, seconded by Dr. Christine Chang. Dr. Miller?
Hi there, Sarah Miller, Section Chair of General Surgery. This was something that I just saw the announcement from Nova Scotia, and you kind of went, well, God, why don't we have this here? So looking into this system, I think we all know that fax is archaic. I'm an 80s baby and faxes were at their heyday, and yet we're still relying on them. So I think we need to get with the times, use an electronic referral system that has better integration with our EMRs and provides adequate information for both the specialist as well as the referring physician. And I think this would be an exciting time to do it because I think this could also fit in with primary care redesign and making certain paperwork jobs much easier as well.
Thank you. Any comments on this motion? Microphone 1, please.
Hello, Brady Bouchard, Northwest. A great resolution, support it, but I wonder if you'd accept a friendly amendment around not just being surgical. Ontario e-referral and e-consult services have been transformative in Ontario. I've seen that over my role with the CFPC, and it would be a point of advocacy while I'm on the board here, I guess. So very much support this. I wonder if you'd be okay expanding that.
What are you proposing for an amendment to this?
You maybe just take out the word surgical, I think.
Yeah, I'd be happy to second that. I wondered if that, but I was like, well, do you start small or go big? So I'd be happy to add that.
Is there any objection to that? Would you accept resubmitting this, well, just taking out the surgical?
Yeah, absolutely.
Okay, so we have the same motion, but it's more broad now, so it will read electronic referral system. Would anyone like to speak further to this? Dr. Brown.
Hi, Mark Brown from Moose Jaw. I think referrals, just to take out the word surgical and just say referral system might be a little bit broad, because are we talking about physician referrals? Are we talking about what kind of referrals are we talking about? Because you get lots of different referrals in the healthcare system. So I do support the motion and support what this is about, Sarah, but I'm just not sure if having it as broad as just referral system is going to is going to hit the mark in terms of what exactly the SMA is talking about. Because family doctor to specialist referrals or specialist to specialist referrals are not the only referrals that happen in the healthcare system. So we need to just be mindful of that.
Are you wanting to just comment, or are you wanting to propose an amendment?
I'm just commenting on the proposal for the amendment.
Thank you.
May I be allowed to speak as a non-voting member?
Please, go ahead.
I'm Mike Kelly. I'm a SMA member, but I'm the new provincial head of surgery. So surgery is working on this, and the Ministry of Health with the RMS system is working on pooled referral as put forward. I do think, though, the momentum of this, sorry, I'm choking. The momentum, it was a macaroon.
Just take a minute. Take a minute, Mike. Because if we have a medical emergency, we're hooped.
Yeah, a bad first impression as the provincial head of surgery. Anyways, this is going forward in the RMS system, and we're looking at it, doing it, neurosurgery. We did it, the hip and knee is looking at doing this, but I think the momentum isn't really there for widespread implementation of this electronic medical system. So I think the SMA could help move that forward and make sure it's appropriately resourced. And I worry about this general amendment dropping surgery off, that it would be something that would take years to implement given the current resources that are allocated to it within the ministry. Thank you.
Thank you. Dr. Groves.
Sean Groves, Larange. I think I would be remiss if I didn't. Kishore and I actually worked together on with the Ministry of Health on a provincial kind of committee that looks at improving access to specialists and diagnostics. And one of the things we've been advocating for years at that level is an e-consult service that would do this same thing. So I don't think that it's not talked about, but I definitely agree that the idea of, or the concept of prioritization and who actually cares about this matters, because we heard, it was pre-COVID, we were talking about a budget to get this going, and then it was post-COVID, we were talking a budget to get this going, but we're still talking about incremental improvements rather than something that's actually going to move the needle in terms of the referral process. So I think it would be helpful for the SMA to put some weight behind this, and so I'd speak in favor of this resolution. And again, I think we can make a friendly amendment on the type of electronic referral program or system we're introducing. But I do think if we're going to look at this as a piecemeal approach, adoption particularly among family physicians who are currently asked to fill out there's about 30 or 40 different ways of making a referral in the province with the way that pooled referrals have come out. We really need an integrated process for family docs to be able to follow, and so I would like to see it as a provincial system.
Thank you. So there has been some discussion both ways about, it's not obvious that it's unanimous that we're removing surgical from this. Mark Brown, was it you that wanted to make the friendly amendment? Sorry, who? Right. So can you please make that a formal motion amendment? And maybe I can help you with or just state your motion. Your amendment that you proposed was removing surgical from this. Would anyone second that amendment? So we are now considering an amendment to this motion to remove surgical from this. Would anyone like to speak to the amendment? The amendment being removing surgical from this motion.
I just wonder if we could, instead of just removing surgical, if we could call it implement a provincial e-consult referral service.
So right now the discussion is about removing
that, but
surgical.
We're going to go down a big long road here.
Yeah, we might. Yeah, I've got all day.
if I could briefly. So, like, e-consult and e is fantastic, and we need to go there too. I don't, like, a friendly amendment should be in the spirit of the original motion. So I would just remove surgical. And the only thing I wanted to say to that is, resolution doesn't mean it's going to happen. It just means where we think it should go. There's no reason that this should stay surgical. You could start there for sure, but the motion should read without the word surgical in it.
Thank you. Would anyone else like to speak to this amendment? Okay, so go ahead.
Claire Kozrowski, Southwest MSA, with my apologies to the speaker. I speak against the amendment. I would prefer to keep surgical in this resolution and perhaps have another resolution with regard to e-consultation, broader.
Thank you. Any other comments? Please come on up to mic 1, please.
I'm Dr. Yusuf Opsangani from Moose Jaw. I'll oppose removing the surgical because the primary motive was regarding to surgical wait list, I believe. So it should stay. Thanks.
Thank you. Would anyone else like to speak to the amendment on this motion? So we're going to vote, and this vote is specifically the amendment that's proposed, and the amendment proposed is that we remove surgical from the main motion. So please open your Slido browser. If you vote in favor of the amendment, we're taking the word surgical out. If you want to leave surgical in, you will vote to defeat this amendment. So let's start the polling, please. Polling has begun. Polling has closed. This amendment is carried. So that means we are going to adjust this as a main motion, and we're going to take surgical out of there. Are we able to do it now on the fly? Okay, thank you. So we're going to work on taking surgical out of there. Now we're going back to the main motion, which now reads without surgical. Would anyone like to speak to this motion? Okay, then I'm going to read the new amended main motion, and then we're going to vote on it. Be it resolved that the SMA advocate to the Ministry of Health to implement an electronic referral system such as that which was recently announced in Nova Scotia to allow for better waitlist management, the ability to triage consultations appropriately, and inform patients and referring physicians and nurse practitioners about available referral options. So, please go back to your Slido browser voting platform, and we will open polling now, please. You have 30 seconds. Okay, polling has closed. So this amended motion is carried. Resolution 16. Be it resolved that the SMA advocate for physicians and work with the Saskatchewan Health Authority to ensure that required organizational learning for physicians is co-developed between the SMA, SHA, and practitioner staff. Courses that become a requirement for physicians to complete must be physician-centered, evidence-based, relevant to each physician's practice and specialty, and compensated appropriately. For standardized courses, i.e. confidentiality of health records, cybersecurity, that the SHA plans to implement, the SMA will advocate on behalf of physicians to assess the necessity of the training for physicians and lobby for appropriate deadlines and frequency of recertification. Moved by Dr. Sheila Parai and seconded by Dr. Pamela Arnold. Dr. Parai?
So this resolution, Dr. Parai from Regina. So this resolution came around the recent mandatory courses that the SHA has implemented in the last year or so. Most of these, as far as I'm aware, was without discussion with the SMA. And basically, most of us found out about it by checking our SHA emails, and all of a sudden there's a pop-up for an SHA required course with fairly short deadlines. So this resolution is brought forward. While some of the courses we can definitely understand cybersecurity when it comes to the use of an organizational email address, some of the courses completely disregard our specialized training. For example, a mandatory hand washing course, for physicians who that's one of our core pieces of training, especially for surgeons who do full sterilized hand washing every day. Frankly, some of the courses are considered insulting by several of my colleagues, to several of our colleagues. So that is the background on this resolution, and I'd be happy to address any concerns or questions.
Thank you. Dr. Jeffrey?
Thank you. John Jeffrey, delegate from Saskatoon, and now the past president. So during this past year, we've had a number of, at times, even fiery discussions with SHA. We have elevated this to their board. We have discussed with the CMO, the CEO. We've discussed it at the Practitioner Liaison Committee, as well as individual meetings. There's no doubt that in order to use the SHA email, we need to have cybersecurity, and we don't have an argument about that. We do recognize that there are other mandatory courses where there are various differences of opinion. We have come to an agreement with SHA that we will sit on a working group that will be looking at future mandatory educational courses. It doesn't help us with the past, but we will be looking at future courses. So I'm not speaking for or against this resolution. I just wanted to comment so everybody's aware that the SMA does have your back and has been really working hard on this, and we have been advocating. Thank you.
Thank you. Would anyone else like to speak to this motion? Then we will vote on this motion. Please open your browsers, your voting browsers, and polling will begin. Polling is closed. This motion is carried. Before we move on to Resolution 17, I want to check with Ivan. Ivan, I got the note. You want to stop before Resolution 20? So you want to do Resolution 20? Okay, thank you. Resolution 17, Be it resolved that the SMA will negotiate compensation for physicians. I'm so sorry. This one is withdrawn. I did not read far enough. That'll save my voice. Let's go on to Resolution 18. Be it resolved that the SMA advocate to the Government of Saskatchewan to, number 1, enforce age restrictions for online gambling. Number 2, consider advertising restrictions such as removing cartoons, celebrities, athletes, and influencers from online gambling promotional materials to protect youth. Number 3, support healthcare providers to access high-quality education regarding gambling disorders and concurrent disorders to enhance diagnosis and treatment. Number 4, ensure that treatment options are widely available to those with problematic gambling. Lotteries and Gaming Saskatchewan should be responsible to build and maintain a fulsome, publicly accessible surveillance plan for their services. Moved by Dr. John Mark Opondo, seconded by Dr. Namdi Ndbuka. Dr. Opondo?
Thanks, Kishore. John Mark Opondo. I should have been choked up like Mike on something that is my area. Online gambling is a pretty new thing, and I think gambling as an addiction is it's known and recognized, but may not be as visible. Part of what this resolution is about is Saskatchewan has recently opened up the gates for this and has appointed a regulator. In 2 months of operation, they've actually had huge amounts of money wagered. I think it was something like 63.1 million, of which the bulk of that, something like 90%, was online gambling. So being able to do this on the cell phone is really easy. Even age restrictions, although it is stated, it's easy to kind of circumvent that. So online gambling as an addiction, I think, travels with other well-known substance abuse and other addictions that we recognize. So the resolution is really, first of all, asking for the Saskatchewan government to enforce the age restrictions. But I think ultimately for us as physicians, if there's money being raised or revenue from this activity, being sure that there are treatment options that will be put in place in addition and along the same lines as other addictions. Thank you.
Thank you. Please, Dr. Ndbuka.
Thank you, Mr. Speaker. Namdi Ndbuka, MSA North Central. I second this motion, I second the resolution, in addition to what Dr. Pondo have provided in terms of information. The Canadian Youth Gambling Survey that was conducted in 2016 showed that 42% of adolescents aged 13 to 19 years of age participated in some form of gambling in the preceding 3 months. So despite the existing steps to verify age when creating online gambling accounts, there is potential of false information to gain access to these services. So this puts underage users at greater risk of accessing gambling illegally and being subjected to potential harm. So the high prevalence of concurrent disorders like alcohol use disorders or even other mental health issues around anxiety, depression, and conditions as such could impact negatively on this underage users. And that speaks volume in terms of the opportunity for healthcare providers to have more awareness around this particular issue. Thank you.
Thank you. Would anyone else like to speak to this motion? Dr. Butt?
Yes, Peter Butt, Delegate, Section of Addiction Medicine. We would like to support this resolution. DSM-5 recognizes gambling addiction. It is certainly something that's highly problematic. With increased access, it increases the risk of harm. It's something that's been mentioned, is often hidden, easily accessed, and the impact potentially on youth is quite significant. The other is that it can lead to significant economic devastation to families and to individuals before it gets recognized and treatment is provided. So we're, as a section, we're strongly in support of this resolution.
Thank you. Please, let's carry on at microphone 1.
Renuka Prasad from Section of Psychiatry. I'm in favor of this motion, but I would also like to add some friendly amendment as well. In the item number 4, ensure that treatment option is there. I would like to say that ensure that evidence-based treatment option, and that's number 1. Number 2 is that instead of widely available, that's fine with me as long as it is publicly funded. It is meant that we're widely mandated, as long as you can able to make those friendly amendment, that will be useful.
So you're proposing an amendment. Would anyone second that amendment? So the proposal is to add under number 4, so it would read, ensure that evidence-based treatment options are widely available and publicly funded. That is moved. Is there a seconder to that?
Peter Butt, Addiction Medicine, yes, we would second that amendment.
Seconded by Dr. Butt. So now, discussion is around that amendment, which is changing the wording to include evidence-based and publicly funded. So any discussion is about the amendment. Dr. Opondo, would you like to speak to this amendment?
Yeah, I think it's a friendly amendment, and I would support that.
It's an amendment, so if you would like to speak to it, then please go ahead.
Can I, as the proposer, say I support it?
You would like to support it? Yes, thank you. Thank you. Anyone else like to support, speak to the amended wording, proposed amended? Dr. Kozrowski?
Claire Kozrowski, MSA Southwest. I would differ with the previous speakers only in that the funding, I believe, ought to come from the gambling interests that are making the money off these endeavors. It ought not to come from the public purse.
Okay. So would you like, are you proposing a second amendment to the amendment that's under discussion?
No, I'm simply opposing this amendment.
Thank you. Would anyone else like to speak to the amended wording? Okay, so can we see amended wording, because we're about to vote on it? And let's be sure we're all seeing and thinking the same thing. So under number 4, please insert evidence-based before treatment options. And then it should read,
Are we amending the motion on the screen before we vote on the amendment?
so that everyone can see it clearly.
Okay,
Yeah,
I will do that
please.
then. Thank
Yeah,
you.
Thanks. And then it should read, are widely available and publicly funded. PowerPoint, am I right? Excellent, thank you. Great. Okay, so the rest of the amendment stands as it is, but I'll reread point number 4, which is where we have a proposed amendment. Number 4, ensure that evidence-based treatment options are publicly funded and widely available to those with problematic gambling. So we are solely voting on changing the wording. So please open your Slido browser and polling will begin. You have 30 seconds. Okay, polling has closed. The amended wording has passed. So now we are back to this as an amended main motion. Would anyone like to speak further to this amended main motion? Microphone 2, please.
Francisco Garcia, Urology, Swift Current, MSA. Just wondering if we should maybe be a bit more clear as what we're expecting out of point 1. And I'm wondering if the first motion or the seconder could, just because the idea is a very nice thing to say, but the adult film industry has been trying to do that for 20 years and it doesn't have any success. I'm not sure what we're expecting in terms of age restrictions and trying to enforce that. And know if there's something specific that they're looking for, maybe we should indicate that. Just because recently I was in a high school classroom doing sex ed, and more than 90% of the grade 10s had recently seen pornographic material. So what's out there is not working.
Thank you. Dr. Opondo?
Yeah, thank you, Dr. Gracia. It is a tricky thing, and I might also borrow from what Dr. Krasnowski said earlier on. It may not necessarily, I might not be the one to give the right operational way of doing this, but my sense is when we had one of our residents kind of experiment, I don't even think they actually asked for a driving license or any kind of confirmation. There are ways in which I believe online they can verify and confirm your age, but that wasn't a requirement. You just put in your age and date of birth, and that was all. So anyone can literally register and get into online gambling if they want. So I think what I'm going to ask is for the SMA and the board, if this is approved, there might be some exploratory work on what that actually is needed to do that.
Thank you. Microphone 2.
Hi, my name's Chris Rustak. I'm a RA delegate for Saskatoon. Without, I guess, with risk of defaming myself, I'm something of an expert in online gambling. There's only one online sports book in Saskatchewan. It's run by the government, and it's hard to sign up for, and they do have age restrictions. All the other sports books are done mostly overseas, and then there's some in Ontario. But I don't know if there's much point to this because it's mostly overseas. And the current one in Saskatchewan is difficult to sign up for.
Thank you.
No, thank you for that information and expertise. Actually, in Saskatchewan, you can participate in online gambling from across the border, and sports gambling using sports icons from all over the world, including Canadian great icons. So I think this is really meant to put the work on the federal government, because I think even other national sports gambling can get into the Canadian context. So that's really the intent, is to catch all gambling, all online gambling.
Thank you. Any other comments on this motion? Then we will vote on this amended main motion. So Resolution 18, please go to your Slido browser and let's open the polling.
Top you bought me, you wrote your gorgeous on it, you took me to your rented motor car and filmed me on the bonnet.
Polling is closed. This motion is carried. Resolution 19, be it resolved that the SMA ask the Saskatchewan Health Authority develop a centralized repository or referral process for all allied health services in the province of Saskatchewan. Moved by Dr. Christine Ryan, seconded by Dr. Namdi Ndubuka. Dr. Ryan?
Well, I
wasn't that nervous about this resolution, but then we had some of the other discussions. So as patient care becomes increasingly complex, our patients need and deserve the care and expertise of our non-physician healthcare colleagues. When it comes to SHA-employed non-physician referrals, there's currently no system for physicians to know who to refer to, where to refer, what referral to use, and God forbid you use the wrong form. Our current setup relies on physician offices to simply know where to send people. But what if you're new to the network or your patient isn't from your network? Referrals get bounced, we and our staff spend hours on administrative tasks, and patient care is getting delayed. Just recently, and that's actually where this came up, one of our pediatricians found out 6 months after they sent a referral that the area that they had referred to no longer had that service, and that they would have to then themselves find another referral form, fax number, and spend that time doing it. This problem is contributing to physician burnout and poor patient outcomes, and we felt this resolution from the Prince Albert MSA would help.
Thank you. Continuing with microphone 2.
So Francis Garcia, Urology, I'm up here a lot. Okay, so just to speak in favor of this resolution, part of my practice, even though I am rural, I do have a subspecialty niche and I get a lot of referrals from all around the province. This would be of great assistance as oftentimes I am using allied health in places that is not my primary practice area. I would allow for easy distribution of the allied health services in places that are 6, 8, 10 hours away from me. So I definitely speak in favor of this, and it's I think an extension of benefit even beyond what Dr. Ryan has proposed, and I think it'd be very helpful.
Thank you. Microphone 1.
Thank you, Mr. Speaker. Namdin Ndabuka, MSA North Central. I speak and support this particular resolution for the obvious point that have been stated already. Physicians' time is very valuable. I think if we cut the time that is being spent on identifying who and which allied professional to refer to, I think that would be very, very helpful to even speak to some of our life-work balance as well. The time spent there is so enormous, and like Dr. Ryan said, if you use the wrong form, the time spent in trying to re-refer and identify the appropriate non-physician colleague to refer to will be very, very tasking. So time saving on this particular centralized pooling system will support our colleagues in streamlining the work that they do. So we speak really in favor of this resolution. Thank you.
Thank you. Would anyone else like to speak about this resolution? Then we will vote on this resolution. So please open your Slido browsers and let's open the poll, please. You have 30 seconds. Polling is closed. This resolution is carried. Resolution 20. Be it resolved that the SMA lobby the Ministry of Health to fund universal, no-cost prescription contraception. Moved by Dr. Danielle No, seconded by Dr. Carla Holinati. Please.
So I'm Dr. No, obstetrician in North Battleford, and a delegate for the MSA Northwest. This is on behalf of the section of obstetrics and gynecology, but we're basically wanting the SMA to support the work that the medical students have been doing, as well as Dr. Lett lobbying the government. There has been a precedent set by the government of BC at just approved universal no-cost prescription contraception, and that's why we worded this resolution like that. It is a human rights issue that all women should have access to contraception, and we hope that the SMA will support this resolution.
Thank you. Would anyone else like to speak about this motion? Dr. Jeffrey?
Thank you. John Jeffrey, delegate at Saskatoon. I am in support of this motion. Just so everybody's aware, we did recently send a letter from the SMA board in support of this motion to the government.
Thank you. Can we come to microphone 2 and then we'll come right back to microphone 1?
Hi, Carla Holinati. I am a delegate for Saskatoon and the seconder of this motion. Obviously, I'm speaking in favor of it. Important to note that money spent on providing no-cost contraception for patients also pays dividends in terms of savings further down the system. So there are predictions that every $1 invested saves about $7 in other costs that we've prevented. And we're not just talking about sort of simple things. Contraception is a life-saving medication in lots of situations. We're preventing ectopic pregnancies. And as an abortion provider, these are people that don't need to see me as well. So, I mean, this seems like such a simple thing that we can do for so many different payoffs in so many different ways, including financial.
Thank you. Please.
Yeah. Ebenezer Hadedigi. I'm just going to add my voice to what has been said. It is real. I mean, people struggling to keep up with being able to afford contraception. These, I've seen it impacted some of our patients, especially in the rurals. With the pandemic, a lot of job loss, people having difficulties with income. We saw lots of, women not being able to keep up. It wasn't their priority during those times. We've also seen immigrant women coming in, trying to get jobs, not being able to afford contraception. And we've seen a lot of women coming in seeking for medical abortions because they were not ready for the pregnancy. So it will be a good thing if the government can fund the prescription contraception. It's going to save the healthcare system, a lot of other headaches and costs down the line. Thank you.
Thank you. Dr. Brabant?
Chris Brabant from Moose Jaw. My only question is about what types of contraception this would cover. Would it only be the combined hormonal contraception? Would it include the IUD, Nexplanon? Like, I want to know if there is expected limits on this, and if there's no expected limits, maybe we should make that more clear in the resolution.
Okay, thank you. Dr. No?
So the BC wording is the exact same, and so all prescription contraception, that kind of excludes condoms because condoms technically are non-prescription and can be already accessed through government funding. So all prescription, that includes combined hormonal contraception, IUDs, Nexplanon, all prescription contraception.
Thank you. Would anyone else like to speak to this motion? Please.
Francisco again. Just I'm wondering a clarification. My only concern is that this is going to be a decision that not the patient nor their healthcare providers are deciding what kind of contraception they're going to get. And I wondered, should we word that it's something that the patient can choose if they want to have Nexplanon, if they want to have Depot, if they want to have OCP, or they want to have a ring or a patch, that's the patient's choice?
Are you suggesting an amendment?
Maybe a clarification or an amendment to maybe make that clear, that it's patient healthcare provider combined shared decision-making, not a ministry governmental decision-making in terms of what contraception that they have access to.
Okay. Would you like to make an amendment?
Yeah, I'll propose the amendment then.
Okay. Can we hear your amendment, please?
Prescription contraception as chosen in shared decision-making between the patient and their provider.
Give me that again. As chosen in?
Shared decision-making between the patient and their provider.
Okay, there's a proposed amendment, and that would add the words or the phrase, as chosen in shared decision-making between the patient and their provider. Would anyone like to speak to this amended phrasing? So discussion now is about the amendment. Dr. Hayton?
Yeah, hi, Susan Hayton. I don't think it should say shared decision-making. I think it should just say, if we're going to change it at all, just based on patient decision or Because shared decision implies that the physician has some say potentially in saying, no, I disagree with that decision, and ultimately it's the patient's decision what's best for them. So I could contemplate some situation where someone might say no, so I don't think that should be in there.
Okay, do you want to make a second amendment to this, or do you want to leave that as a comment?
I guess I don't think an amendment is necessary, because I think, as was said in BC, this is what is said, and it applies to everybody who wants a prescription for a contraception of some type.
Thank you. Dr. Rapp?
Yeah, I really appreciate that this is actually a very important health issue for women, and I'm very thankful that it comes to a place like this and that people support it. I would speak against the amendment just for the simple fact that keeping it simple makes it actually freer for providers to give patients the contraception of their choice. It's implied we're advocating, not making decisions for the patient. So we're advocating for, a higher level of financial support, I guess, and access for patients, but not for individual decision making. So I would just keep it the way that it's written.
Thank you. And for the process, people in the room, I did not ask for a seconder. Discussion has already started, so we'll take that as an implication that someone thought discussion was warranted. Brian, I'm looking at you. Can we go back to microphone 1?
Yeah, I would just speak against it as well, because this is clear and people are more likely to choose a long-acting contraceptive if it's not cost prohibitive. And I don't think the government would also go against that, because in the long run, long-actings are more cost-effective than paying for birth control pills every month. So I don't think that would be necessary or helpful.
Can you tell us, are you for or against this amendment?
I'm against the amendment, yeah.
Thank you. Speaking about the amendment now,
Yeah,
please.
speaking about the amendment, Dr. Percival, the reason I think that this is important, like the amendment is important, and the reason I'm in favor of the amendment is because the government is already controlling the type of prescriptions we are allowed to give our patients. We need to do metformin and a sulfonylurea before we can use empagliflozin. Like, we already have a stepwise approach that the government is enforcing upon us in order to get EDS coverage. I do worry that this will come in under like an EDS thing, and it will say you need to fail on an oral contraceptive before you can get a long-acting one. And that's the only concern that I have. And maybe while it doesn't need to be in the amendment itself, maybe the SMA can keep that in their mind as they are advocating for this at the ministry level.
Thank you. Would anyone else like to speak about the amended motion? Please.
Brianna Davis, North Central MSA, Prince Albert. I just would like to speak against the amendment. I think the word universal implies that it would include all contraception, and I think that it just makes it a little bit more complicated.
Would anyone else like to speak about the amended motion? So, because this one was a little bit less complicated, I'm just going to read it out again with the proposed amendment, then we're going to vote on the amended wording. Be it resolved that the SMA lobby the Ministry of Health to fund universal, no-cost prescription contraception as chosen in shared decision-making between the patient and the provider. So we're voting to accept this amended wording or to defeat it. Let's open the Slido browser. Polling.
I'm sorry, Dr. Viswanathan, you're actually voting only on the amendment. All you're voting on is whether to amend.
Whether we should, yeah, sorry.
Accept the,
whether we're
you
putting
actually
new
said
words
that you're
in.
voting on the amended motion. You're not. You're voting on solely on the question of whether to amend the motion by including those extra words.
Thank you. I was not clear on that. Thanks, Brian. And Brian was the person I was looking at before. So we are voting only on whether we should add that phrase. So should we amend the wording? So let's bring the Slido up again. And let's open the polling. Polling has begun. Polling has ended. The amendment is defeated. So we will now return to the main motion. And you see the wording in front of you. Is there any further discussion about this motion? In that case, we will now vote on Resolution 20, as you see in front of you. So let's open the Slido polling again, and you will have 30 seconds. Polling has begun. This motion is carried. There is a comment from the SMA about this motion in anticipation of it passing, and that is that the resolution that has just passed is not the only way that the SMA has supported universal access to contraception. Recently, the SMA Board of Directors, as Dr. Jeffrey mentioned, sent a letter endorsing the efforts of the U of S student group, Universal Access to Contraception Saskatchewan. This group has created a letter of support to garner support from physicians. At last count, 217 Saskatchewan physicians had signed this letter. There are now probably many more. The letter is going to be given to the Minister of Health next week. The slide on the screen contains a QR code that links to the letter. If you would like to sign the letter supporting universal access to contraception, please scan the code and follow the directions there. So we'll leave that on the screen. Before we get ready to adjourn, is there any other business? In that case, at the end of a full day and a great day, let me outline the evening for you. Before I do that, though, please remember to fill out today's evaluation form. SMA staff really value our feedback and do strive to improve the RA. If you are not joining us tomorrow, please book in your calendars the 2023 Fall RA to be held on November 3rd and 4th in Saskatoon. Before I adjourn today's session, I would like to invite you on behalf of the SMA to a cocktail and appetizer reception that will begin at 5:30 p.m. in the Southwest Room. What a great opportunity to reconnect with colleagues. At 6:30 p.m., we will return to this room for the awards and presidential installation. Dinner will be served at 7:30, followed by entertainment from the Johnner Brothers. And we are slightly early. I would entertain a motion to adjourn early. I see a motion and a seconder, and we'll just have a show of hands. Anyone in favor? That motion is carried. Have a great evening.